I guess we're doing the season finale. Let's go. Hello and welcome to MK's Exam Secrets. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at exam questions in a clinical course. Today we're going to be looking at Season 2, Episode 6, the Pediatrics finale. And if you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. And because this is the season finale, we shall be covering 10. Hey, you heard me right. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 questions. So I hope you're ready. And you already know the drill for these videos. You may pause the video at any time to scream the answer at your screen, as well as write it down on a piece of paper. Beginning with our question 1. A 28-year-old mom gives birth to a 4.9 kg baby via elective cesarean section at 39 weeks of gestation. The APGAR score at 1 minute is 9 out of 10. The baby is taken to the NICU. Define what large for gestation is. Give 2 most likely reasons why this baby is large for gestational age. Apart from increased incidence of cesarean section delivery, give 4 possible complications of large for gestational age babies. What investigations are important in this case? So you may pause the video. And here comes the answer. So remember, when you are talking about large for gestational age, this is a child that has reached a certain gestational age, but compared to the mean population, they are actually they're weighing much more than the mean population. So this is just defined as an infant whose weight is greater than 90th percentile for the normal gestational age of that population. Then, of course, the reasons why we think this child is actually large for gestational age. Of course, this child has passed term. And for a child that's at 39 weeks, it should be around 3 to about 3.5 kilograms. But this child is at 4.9. This is already well above the 90th percentile if you look at the weight distribution curves for the babies. Then, of course, the child has passed term and the child also required cesarean delivery. Despite them having actually an APGAR score of 9 out of 10 after 1 minute, which is good, they actually needed a cesarean sections. And it is for these reasons that this child is most likely large for gestational age. So apart from increased incidence of C-section delivery, give 4 possible complications for large for gestational age babies. Of course, these individuals are susceptible to hypoglycemia, which is often attributed to hyperinsulinism, polycythemia, breathing difficulties from, of course, an enlarged tongue, which may be associated with Beckwith-Wiedemann syndrome. Of course, you may have birth asphyxia from a difficult delivery. You may have birth injuries such as a shoulder dystocia, fracture of the clavicle or the limbs, as well as meconium aspiration. Then what investigations are important? You want to do a random blood sugar because this child is going to need glucose and you're going to have to breastfeed this child as early as possible. Then, of course, a full blood count and differential to rule out any infections and also to pick out the polycythemia. Serum electrolytes. Children who are large for gestational age often tend to have hypocalcemia and hypomagnesemia. Then, of course, serum bilirubin. Because of the polycythemia, there may be increase in breakdown of the red blood cells and, of course, an increase in bilirubin levels. Moving on to question 2. Give 10 side effects of corticosteroid therapy. I think this is one of the easiest questions that has ever been asked in a pediatric exam. Anyways, most of you may not even know the corticosteroid therapy. Remember that corticosteroids is actually used in obstetrics, especially to give to mothers to help with fetal development and fetal lung development rather. And actually, did you know that they are not only beneficial to the baby, but they are also beneficial to the mother? For example, if the mother has deranged levels of hepatic hormones, for example, in the HELP syndrome, the corticosteroids can actually help in stabilizing this. Anyways, here comes the answer. So you have cataracts, ulcers, skin striae, skin thinning, skin bruising. You have also hypertension, hirsutism, or hyperglycemia. You have infections. You may have necrosis, avascular necrosis of the head of the femur, glycosuria, osteoporosis, even obesity, immunosuppression, which is a very big one, and then of course diabetes. So if you look at the first letter of each of these, it makes a very nice mnemonic saying cushingoid. So cushingoid. Okay, cushingoid. That's the 10 side effects of corticosteroid therapy. Moving on to question 3. Naomi is a 3-year-old. Her mother brings her to the emergency room for complaints of fever for 3 days. What relevant questions will you ask? What relevant questions will you ask? You may pause the video at this point, and here comes the answer. So remember that you should actually think of it like you're taking a history in this case. So you want to ask questions surrounding the fever. Has the fever changed over the 3 days? How frequent has she been experiencing the fever? Is there any clear pattern to the fever? Of course, it may be continuous or cyclical. All these things have bearings. If it's cyclical, then you're thinking maybe this could be a malaria. And of course, what triggers or exacerbates the fever? What are the relieving factors? Does the child take any medication? And of course, are there any of the following associated symptoms? Seizures, syncope, headaches, which may point towards CNS infections, difficulty breathing, chest pains, which may point towards respiratory infections, abdominal pains, vomiting, as well as diarrhea, which may point towards GIT infections, night sweats, rigors, weight loss, swellings anywhere, or any skin rash or any skin itching. Of course, the night sweats and the weight loss and the anorexia may point towards, of course, TB. Then, is there any history of a recent travel? Does this child sleep under a mosquito net, a treated mosquito net? And where actually do they stay? Because this could be a malaria. That's another question that you should add to the list of questions. What's the immunization status of this child? Did they receive all the under 5 vaccines? Then, of course, what's the past medical history? Have they had malaria, upper respiratory tract infections, even urinary tract infections because it's a girl? Then HIV, even TB as a past medical history. Moving on to question 4, Peter is a 1 year, 6 months old. He is brought to the malnutrition ward by his mother with a history of diarrhea and poor appetite for the past 2 weeks. His anthropometry is as follows. Weight for age is less than 2 standard deviation. Weight for length is less than 2 standard deviation. Length for age is less than 3 standard deviation. And of course, edema is +1. The first question is give 3 criteria for inpatient management in severe acute malnutrition. Then, according to the criteria above, does Peter qualify to be admitted for SAM? If so, how does he qualify or not qualify? What fluid will you use to manage Peter's diarrhea? What is the advantage of using this fluid? Mention any 3 acute complications that increase mortality in children admitted with SAM. You may pause the video at any point, and here comes the answer. So the admission criteria usually vary, but what I've seen, the most common are going to include a weight for height that's less than -3 standard deviation, a mid-upper arm circumference that is less than 11.5 centimeters, severe visible wasting, so your features of wasting, as well as bipedal edema. In individuals that are below the age of 6 months, then you would actually have, if they have a poor appetite, then that would be one of the things that would warrant admission. But if we look at this child, actually, this child has a weight for height that is less than -2, though this doesn't fall under severe, it would be more of a moderate, but because of the presence of the bipedal edema, remember that bipedal edema is usually an indication of severe acute malnutrition, regardless of you having this weight for age that's less than -2. Let alone they have a length for age that is less than -3 standard deviation. Also, they have a history of diarrhea, so they do have some dehydration. Then, of course, the fluid of choice that you're going to be using is, of course, rehydration salts for the malnourished children, or Risomol. This is because it's going to be having a low concentration of sodium, a higher concentration of potassium and glucose compared to your standard WHO ORS, as well as your WHO low osmolarity ORS. The 3 things that can actually increase mortality in children admitted with SAM include things like hypoglycemia, hypothermia, even dehydration. You may also have infections and electrolyte imbalances. Question 5. Takondwa is a 15-year-old black boy. He is smaller than his peers and doesn't usually take part in physical activities at school. His eyes are usually jaundiced. He usually frequents the emergency department of his local hospital, and his usual presentation includes painful bones and fatigue. He has received blood transfusions several times before. What is the most likely diagnosis? Give 2 laboratory investigations that would confirm the clinical suspicion. You notice that Takondwa has a limp as he walks. Give 2 reasons why this may be so. When Takondwa was born, he did not show any evidence of illness until he was 7 months old. Why? So you may pause the video at this point, and here comes the answer. So remember that anyone that comes in with these recurrent features, recurrent symptoms like this presentation of this recurrent blood transfusions, recurrent bone pains, you should think that they possibly could have sickle cell anemia. Remember, there is sickle cell trait, sickle cell disease, and sickle cell anemia. Now, the difference is this. With sickle cell trait, these are just pretty much carriers. So they have one normal hemoglobin gene and another sickle cell hemoglobin gene. Then sickle cell disease, which is kind of like the moderate form, this way you have one abnormal sickle cell gene plus another abnormal hemoglobin gene, not necessarily a sickle cell gene. It could be hemoglobin C, for example. Then the sickle cell anemia is they have both abnormal sickle cell genes. Of course, these are going to present you with similar clinical features as presented in this question. Of course, your laboratory investigations that would confirm the suspicion, you could either do a peripheral smear or sickling test, as well as HB electrophoresis, which is the gold standard in the diagnosis. So you notice that he's having a limp. So the limp could be due to one of many things. It could be due to either a vascular necrosis of the head of the femur as a complication of sickle cell. It could be due to musculoskeletal deformities that are as a complication of sickle cell. It could also be due to osteomyelitis. Now remember that osteomyelitis in sickle cell patients is often attributed to salmonella as compared to the Staph aureus in the majority of the population. Then the reason why this isn't found in individuals that are below 6 months predominantly. Remember that before 6 months, the bulk majority of hemoglobin in the body is going to be fetal hemoglobin. And remember that fetal hemoglobin has 2 alpha chains and 2 gamma chains. And the conversion of fetal hemoglobin to adult hemoglobin that has 2 alpha chains and 2 beta chains happens roughly around 6 months or within 6 months. So as this concentration increases, remember that sickle cell, the defect is going to be on the beta chain of hemoglobin. So that's why fetal hemoglobin is not affected, and you won't get this presentation when someone is below 6 months old. You would often see it after 6 months. Question 6. A 14-hour-old newly born baby of Mukuka is sent to your neonatal unit because he has a wound on the back. You perform a quick assessment and conclude that it's a term infant with good perfusion and respirations. Baby has an obvious defect along the spine on the lower back. There is a sac with neural contents in there. The tone in the lower limb is reduced with absent reflexes. He has a patulous anus. What is your most likely diagnosis? What complications or associations do you expect this baby to develop? What drug given in pregnancy could have prevented this? If Mukuka's baby only had a patch of hair in the lower back and his limbs were normal, what would you call his condition instead? So you may pause the video. I know if you have never seen this, if you've never heard of this condition, it will be very difficult for you to pick up. But if you have, this is one of the most straightforward questions and the most knee-jerk responses that you can ever get as someone taking a pediatric exam. So here comes the answer. So remember that the most likely diagnosis is obviously spina bifida, cystica, or you can refer to it as open spina bifida. So this is where you have a defect in the closure of the vertebra and you find that the membranes are exposed. You could have a myelomeningocele, and then of course you may have even neural tissues exposed. So some of the complications and associations may include things like hydrocephalus, kyphosis, and scoliosis, and neurogenic bladder, where you may have recurrent UTIs, you may have hydronephrosis, and eventually kidney damage. Then, of course, the drug that is often used to prevent this is folic acid or folate. Then, of course, if the baby only had a patch of hair in the lower back, then you would refer to this as spina bifida occulta. Moving on to question 7, match the words or phrases on the left with the appropriate or relevant phrase on the right. So here you have enteric fever, Plasmodium falciparum, breast milk, ABO incompatibility, sickle cell anemia, paucis paradoxus, oligemic lungs, meningococcemia, respiratory distress, ANCA, ANA, and anti-double-stranded DNA, 460 to 490 nanometers, encapsulated bacteria, SLE nephritis, surfactant deficiency, toxic myocarditis, tetralogy of Fallot, severe asthmatic attack, secretory IgA, histidine-rich protein 2, and then gangrene. So you may pause the video and start matching what you have on this side of the table with what you have on this side of the table. So here comes the answer. Now, with enteric fever, of course, it often tends to cause toxic myocarditis as some of the complications, which are often seen after the 3rd week or during the 3rd week. And of course, Plasmodium falciparum has an histidine-rich protein 2, which can actually be used to test in the rapid kits for malaria. Breast milk often has a secretory IgA. Now, with ABO incompatibility, I found that the only option that was left was 460 to 490 nanometers, of which I don't know if that's something to do with wavelength, but if you have any idea, please comment in the section below. Then, of course, sickle cell anemia can cause gangrene as it blocks the blood vessels. Paucis paradoxus is often seen in severe asthmatic attacks. Oligemic lung fields are seen in tetralogy of Fallot. Meningococcemia is an encapsulated bacteria. Respiratory distress is often attributed to surfactant deficiency. And then, of course, these antibodies are seen in SLE nephritis. Moving on to question 8. A 24-month-old girl presents to hospital with history of diarrhea and vomiting for 4 days and anorexia for 2 weeks. The mother has recently fallen pregnant, but she has recently separated from her husband. On examination, the child is miserable, apathetic, and has bilateral pedoedema and dermatosis. Her weight is 7.2. Her muscles are wasted. What is the diagnosis? List 5 criteria or critical conditions that you must manage in order to save the life of the child within the first 48 hours. What is the expected weight for age for this child? Give differentials that you need to rule out every time you have such a case. You may pause the video, and here comes the answer. So this is a 2-year-old girl that's presenting to you with diarrhea and vomiting, kind of like a similar question that we answered earlier on. So for 4 days and anorexia for 2 weeks. The mother has fallen pregnant. Remember that if she's fallen pregnant and she's separated from the husband, she's going through a lot. So she may not necessarily give all the attention to this 2-year-old baby. And of course, this child is going to be miserable, apathetic, and bilateral pedoedema, and her weight is 7.2. She also has dermatosis, although dermatosis is usually not one of the criteria that we use to diagnose severe acute malnutrition. So obviously, this child has severe acute malnutrition. Now, the 5 things that you should look out for, like I said in the earlier slide: hypoglycemia, hypothermia, dehydration, electrolyte imbalances, infection. Now, our expected weight for age for this child, remember that the expected weight is 2 multiplied by 4. You add the age of the child. So 4, you add 2, that will give you 6, multiplied by 2, that will give you 12 kg. Then give differentials that need to be ruled out every time you have such a case. So you make sure that you rule out any HIV infection because you want to start them on treatment if they're HIV positive. You rule out other conditions like tuberculosis, pneumocystis jirovecii pneumonia, malaria, vitamin A deficiency, severe anemia, candidiasis, and even worm infestations. You always have to rule out these conditions in all patients that come in with severe acute malnutrition. Moving on to question 9. Chimuka is a 7-year-old positive girl brought to the hospital by her aunt. Both her parents are deceased. Of late, Chimuka has been coughing and wasting away. She actually presents in respiratory distress. If Chimuka wasn't NVP naive when she was first put on ART at age 1 year and she hasn't changed medication since, what drug regimen is she most likely on? Give 4 chest findings that will be consistent with a massive right side pleural effusion. Give 2 diagnoses that would explain the pleural effusion in this case. What other findings outside the chest would support your number 1 diagnosis? Okay, and here comes the answer. Then remember that if this person was NVP naive, she may have been on prophylaxis with the AZT, 3TC, and nevirapine. So most likely she may have been put on ABC, 3TC, and boosted lopinavir. Then, of course, the 4 chest findings with a massive right-sided pleural effusion include asymmetrical chest expansion, deviation of the trachea to the left side, the opposite side. You may also have a trail sign, which is standing out of the sternocleidomastoid on the left side. You may have stony downness to percussion on the right side, reduced air entry on the right side, and, of course, reduced vocal resonance on the right side. Then 2 possible diagnoses include pulmonary TB as well as pleural Kaposi's sarcoma. Now, for this last part here, the answer actually should change for this last part here. So what other findings outside the chest would support your number 1 diagnosis? So like I said, this must have been on the history. I may have sorry about that. I may have misinterpreted the question when answering this. So of course, if we're suspecting that there's pulmonary TB, then you may actually get features of wasting. So yeah, you may have features of wasting in someone that has TB. You may have hepatomegaly. You may have generalized lymphadenopathy. And of course, there will be these things like the presence of HIV, wasting, cough, and even that despite her being on treatment. But of course, the findings that you would get outside may include things like wasting, like I said, things like generalized lymphadenopathy. You may have hepatomegaly, you may have splenomegaly. That's in cases where there is disseminated TB. Then, of course, in Kaposi's sarcoma, you may get this purple lesions characteristic in the hard, in the soft palate of the mouth. Then here comes the last question. A 12-year-old boy presents to the emergency department with a history of fever for the last 1 month. He also has a history of chills, malaise. On physical examination, he is febrile with a temperature of 39.3. His blood pressure was normal at 110/40. He has no rash. Auscultation of the chest reveals clear breath sounds. He has a grade 3 out of 6 pansystolic murmur heard burst at the lower left sternal border. Describe all the examination findings you will look out for. Give 10. What investigations will you carry out on this patient? What is the most likely diagnosis? You may pause the video. So let me give you a background of this question. So this is a child that has come in, is 12 years old. They have a fever. They have a murmur. Remember, a fever plus a murmur would point you towards an infectious endocarditis. Isn't that so? But remember that in children, the most common cause of fever, murmurs, and this kind of presentation would most likely be an acute rheumatic heart disease. So here comes the answer. So if you're suspecting that this person has acute rheumatic fever, you can look for the other features of acute rheumatic fever, things like subcutaneous nodules, chorea. You may have a chameleon or darting tongue, which is where you ask the patient to protrude their tongue and then their tongue is unable to be sustained as they are protruding their tongue, so it will be darting like a chameleon. Then, of course, a milk-maid grip, where the patient is unable to maintain the grip on the examiner's fingers. You may have a pronator sign, where the hand is out. When the hand is outstretched above the head, then the forearms tend to pronate. Then you may also have polyarthritis. You may have a pericardial rub, a soft S1 heart sound. You may have an S3 gallop. You may have an audible click during speaking. You may have also clumsiness of the hands. And of course, what investigations would you carry out in this patient? An antistreptolysin O titers, anti-DNase B. You may have anti-hyaluronidase antibodies. You may even do a blood culture. You may do an ECG and echo, a chest x-ray, ESR, C-reactive protein, full blood count with a differential. So your most likely diagnosis obviously would be your acute rheumatic heart disease, most likely affecting the mitral valve, causing a mitral valve regurgitation. But of course, we would have to rule out an infective endocarditis, bacterioinfective endocarditis. I really hope that you enjoyed this video. If you did, hit the subscribe button, hit the like button, and do not forget to follow us on Facebook at Dr. MK7. I wish you all the best in your exam. I'll catch you in the next season of these episodes to Zambia and beyond. My name is Dr. Moses Kazevu.